So I'll answer those questions in reverse because I think that will help frame things up. I think it's going to be a long journey, but I do think eventually that these therapies will be covered by insurance, because right now most of them are not. You can find some obscure, insurance providers and things like that where you can get things covered. We've also got a lot of clinics doing shady things with their medical billing to get it covered for patients. But eventually over time, I do think that there are going to be indications for these therapies. However, I still think there's going to be huge limitations with that, because we're in this medical society right now where all of these treatments are based off of imaging. You go in, you have knee pain, you get an x-ray, you've got knee osteoarthritis. So now you are approved for cortisone and or hyaluronic injections into the knee joint. That's it. They're not doing anything else. They're just putting it in the knee joint and that's it. Where a lot of the times patients with knee osteoarthritis, they have pain coming from other structures. You got the infrapatellar branch of saphenous, which is a huge one if anybody's got medial knee pain. You've also got the coronary ligaments, which are commonly damaged when you have a meniscus injury. So if you just inject inside the knee joint, you're not going to get the ligaments that attach the meniscus onto the tibia. You've got the MCL, the LCL, you've got the patellar tendon, you've got the infrapatellar fat pad. All of these things can cause pain, but you're only getting those injections into a knee joint and that's it. And so I'm afraid that the industry is just going to replace PRP with the steroid, which will be a good thing. I'm all for that, and I think that's going to be great, right? If we can, even if we can just replace it, I don't think it's the best model, but it's still better than steroids going in a joint. But where I think it's still going to lack is the art of these injections, which is how do I find out what structures are contributing to my patient's pain, which I'll tell you 90% of the time I'm making my diagnosis based off of me talking to the patient, that's called the history, and me putting patients through different maneuvers, orthopedic tests, neurological tests, muscle tests. That's the physical exam. In 10% of the time, I'll use imaging, but my success rates are such that I don't ever step back and go, oh man, I'm really missing something. Maybe I should do more imaging. No, my success rates are very good because I'm really selective and I'm thorough in my physical exam to have an understanding of, oh, it hurts when I push right on this nerve and there's nothing else there. Well, that's not going to show up on an MRI. That's not going to show up on an x-ray, that's for sure. But we treat that and patients get better. And so I have a feeling that even as the industry moves towards having some of these things covered by insurance, if they don't release some of the restrictions on the indications or the ability to do more things during that procedure, then I will likely still continue down the exact same path I am, which is heavily focused on cash base and, actually taking more time with patients to figure out what's going on so that I can get them the results that they want.